Moving on to cancer surgery in women. For this, I would like to invite Dr. Saket Patwardhan. He's a consultant radiologist at Eurocul Baner and Speckling Super Speciality Center, FC Road. A radiologist plays a pivotal role in the early diagnosis of cancer, and hence he is the ideal chairperson for this session, Dr. Saket Patwardhan. I would also like to invite Dr. Prashant Soitkar, sir. He's MBBS family physician practicing at Pancard Club Road, Baner. He's ex-medical officer in Aditya Birla Hospital, Chinchwad, Pune. He's highly respected and dedicated general physician who has been the first point of contact for numerous patients seeking treatment and guidance. May I request the chairpersons to please introduce the speaker for the next session.
I would like to invite on the stage Dr. Amit Parasnis. He is a MS, DNB, MNA, MS, FMAS, FICS Oncology. He is a consultant surgical oncologist, head of the Department of Surgical Oncology and Surgery, visiting fellow at Memorial Sloan Kettering Cancer Center, New York, and National Cancer Center, Tokyo. Areas of interest: pancreatic and colorectal surgeries, advanced laparoscopic surgery, and video-assisted thoracic surgery. Please.
Good morning, everyone. I wish to thank the organizers of BMACon and Manipal Hospital for giving me this opportunity to present my thoughts before you. As you can see, my topic is slightly different topic. I would rather venture and say that it's more of a philosophical topic than an academic topic. Cancer surgery in women, what has changed and what has not. What I realized was that change is one of the only constants in our lives. Like I recently changed my practice from a different part of the city, a bigger hospital, to Manipal Hospital, which gave me this opportunity. As Dr. Pramod Umarji said in his inaugural talk, that one has to keep on learning, unlearning and relearning. So change has to be there. And when I was asked to give a talk in this conference, I thought about giving a talk about what has changed in my practice as far as women's cancers are concerned over the past 22 years when I have been practicing surgery. And why women? Women have always been a neglected part of our Indian society. This is a very cliched thing to say. But then yesterday, I came across in yesterday's Lok Satta, there was a news item, there was a column about something called as #4B movement. I don't know if anyone has heard about it. It was the first time yesterday I heard about it. So oppression of women and neglect and women's issues not being taken care of is not only an Indian thing. It was there in South Korea also. And so much so that they started a movement called as #4B, where they started to avoid 4 things. In the Korean language, they began with the letter B. It was like no dating, no marriage, no kids, no sex. So this was what the women started in South Korea. This movement has spread to the Western world also. So the time has come that women take their health in their own hands and not be dependent on their spouses or their parents or anyone else for making decisions for them. Still in our OPDs we see the husband makes the decisions for the wife and the son makes the decision for his mother, although they are very capable themselves of taking decisions about what they want to be done with their bodies, how they want to be treated. So I thought this was a very good topic. Secondly, we see a lot of women's cancers on the rise. Although there are other cancers in other systems which affect women, I would like to focus on the organs which affect, which are specific to female sex. And let us see what we can talk about. This is not going to be more of a academic or a very lecture with a lot of information, but it's going to be more of a discussion and more of some thoughts being exchanged or some philosophy which I want to convey. So, as we all know, cancer is no longer a disease which does not have any treatment, which is so as to be called in the previous days asadhya. So cancer can be treated. We always keep telling patients that cancer can be treated, all cancers can be treated. Most cancers can be cured if detected early and treated properly. And all cancers, the patient's problems, the patient's troubles can be reduced by proper treatment. So cancer is not a sentence, like meaning like a prison sentence, it's just a word. It can be treated like any other disease like diabetes, hypertension. Lots of lines of treatment are available. If one doesn't work, the next line can be tried. And cancer does not mean that you have to stop, that the patient's life has stopped, the patient's life has a definite end to it. It does not have to mean always that way. We do have treatment which can cover most types of cancers. And in my career of around 23 years, I have seen cancer surgery evolve to a large extent, and cancer surgery as far as history is concerned has evolved from bigger surgeons, big egos, super radical surgeries to smaller surgeries, organ conservations, lesser morbidity, better cosmesis, better function. So this is all, I've been lucky to see all this in my surgical career. So this is a typically optimistic surgeon which always will show the bright side of things to patient. Even though you don't have half a colon, it is still not a full stop. A semicolon is still better than a full stop. So the purpose of putting this slide is that cancer surgery or removal of organs does not mean stopping daily functions, stopping your daily routine, getting away from your work. It can mean a brief delay or a brief stop, and then you can almost go back to your normal capacity. A lot of things have changed in the ancillary branches which help surgeons to get their patients better. Better anesthesia is one of the biggest advantages which we have had, from ether to halothane to sevoflurane and now to isoflurane and drugs like dexmedetomidine. The anesthesia has become safer, more effective and less painful for the patient. When I started my career, the only antibiotics available were cefotaxime and amoxicillin. And now we have a plethora of antibiotics, although I must say our medicine colleagues would now believe that we have reached our plateau where more antibiotics may not be discovered very soon or very fast. This is true especially after COVID, that intensive care has developed as a branch and it has become popular amongst medical students, and that has helped tremendously for branches which require major surgeries, that is surgical oncology, where patient care was taken over by a team of intensivists, and post-operative respiratory monitoring, cardiovascular monitoring, hemodynamic monitoring took a huge step forward in betterment. Another thing which we must thank our paraclinical colleagues is better understanding and better involvement of nutritional therapies, physiotherapy and rehabilitation in getting the patients better. And needless to say, in cancer, there was a quantum leap in chemotherapy, targeted therapy, radiotherapy, which improved local control rates and survival. When I started practicing cancer surgery, there were around 200 or 300 chemotherapy drugs which were there available to the chemotherapy medical oncologists, and now the number must be in thousands. So they also have to keep up with what is going on, but that has helped the patient. Patient gets more choice, patient has access to more different lines of treatment. So coming to the most common cancer in women, that is breast cancer, let me take this opportunity to inform you all that in the recent past, breast cancer has replaced carcinoma cervix as the most commonest cancer in women in India. And like now, in a not so fortunate way, India has become at par with the world, where breast cancer is the commonest cancer in women. But when I see how breast cancer treatment and surgery has evolved over the past, what do I see? There is definitely increased awareness about breast cancer because of various social media campaigns, various celebrities endorsing breast cancer, a breast cancer month and a breast cancer day being celebrated. So what I see is people or ladies from rural areas, from villages, from tier 2 cities, they also are aware about their breasts, about their health of their breasts, and they would not now hesitate to come to doctors or to their family practitioners to get any queries about any breast diseases resolved. So this has definitely helped in getting cases at an earlier stage, and as we know, earlier stage diagnosis and treatment means better survival and better cosmesis also. Apart from that, digital mammography is a very good technique, is a very good investigation which has helped in identifying breast cancer in the pre-clinical stage and thereby facilitating again early detection. The role of screening mammography cannot be overemphasized. Any woman above the age of 45 should get a mammography done every year till the age of 60, 65, and that will give her an advantage of early detection and improved survival. One more thing which has changed is that now more and more patients are being given something called as neoadjuvant therapy. That means instead of operating them upfront, we would treat them with chemotherapy first. The advantage being that micrometastases are being taken care of and the sequence of treatment changed to neoadjuvant chemotherapy followed by surgery followed by radiotherapy means that you get better survival and better opportunity to do a reconstruction and give her a better cosmesis. There is also been developments in targeted therapies. As we all know, there are different types of receptors on the breast cancer cells, and we try to identify targets, these are these receptors, and then identify or create some antibodies or some drugs which will target only these particular receptors, thereby reducing the morbidity of treatment and improving the efficacy. Another thing which has changed is that previously the axillary lymph nodes were removed from level 1 to level 3, and that sort of gave a bit of morbidity as far as the shoulder movement and the arm edema was concerned. But that now with better understanding, we are able to reduce the magnitude of axillary surgery and reduce these all problems which will hamper in day-to-day life of the working woman. And needless to say, better reconstructive techniques and better radiotherapy has improved local survival and the cosmesis also. And as a result of all these particular things in our arsenal, we are able to achieve more number of organ conservations, more number of breast conservations. So previously it was mastectomy, axillary clearance in toto, may or may not take chemotherapy, no reconstructions, high rates of local recurrences, bad survival, and now we try to conserve as much as and whenever possible. We try to reduce the number of axillary surgery, axillary nodes removed. We offer reconstruction, we offer in situ plastic surgery with the help of oncoplasty. We offer smaller courses of radiotherapy which will help the patient get back to her work. Like previously it was 6 weeks, now it can be done in 2 weeks. We do have less local regional recurrences. We do offer more neoadjuvant chemotherapy instead of getting the patient directly to surgery. But what has not changed, there is still a role of mastectomy. You have a 65-year-old lady coming to you with a large breast lump and she has no access to different treatments, different radiotherapy protocols, or she may not be in a position to take chemotherapy because of comorbidities. You can still offer her a mastectomy, she can still get good survival. So mastectomy is not out of the game at all. Basic chemotherapy drugs which cost less than a few thousand rupees or maybe less than even 2,000 rupees still play a large role, and they do provide an advantage. So it is not a very big thing if your patient can't afford large number of chemotherapy drugs or advanced chemotherapy drugs or targeted therapy, even the basic treatment is also going to help her to achieve some sort of survival advantage. And so that role cannot be overlooked. It is still there. People who can't afford or they don't have access to resources can still be given endoxan and adriamycin and they still have good results. Adriamycin is such a wonderful drug and a very cheap drug, and that particular drug itself will offer a very big advantage. And it's a very, apart from a few sort of slight emetogenicity, there are no side effects. So it is still a drug which can be used very easily, cheap, and will give good results. So that has not changed. One more thing is, suppose a lady from the rural area or from a village does not have access to mammography or screening mammography. Simple self-breast examination will also keep her aware about her breast health, breast anatomy, and make her come to her family practitioner in case she has any breast lumps or anything. So that is still there, that has not changed. Simple basic drugs which are used for ER, PR, estrogen receptor and progesterone receptor positive patients, which form almost 50 to 60% of all breast cancer patients. Simple drugs, cheap drugs like tamoxifen, anastrozole, they are still there. So if they can be given to your patients, patients will definitely have a degree of control and a degree of increased survival advantage. So we cannot ignore this. These drugs are not yet gone. So whenever new things come, old things always don't have to go out. So for example, let us see a simple case of a 60-year-old lady with a 3 by 3 centimeter lump in her upper outer quadrant of her right breast. Now previously, we only had one choice, mastectomy or removal of the breast, complete axillary clearance, and then send her for chemotherapy. But now we have so many choices. This was the first choice in her in the past maybe. Now we can just offer her a simple breast conservative surgery, just lumpectomy, some axillary sampling, with or without reconstruction, depends on her comorbidities, depends on her wish. We can offer her something called as oncoplasty, wherein the plastic surgery principles are used to mobilize the breast tissue, breast pillars, and give her a better cosmesis, and achieving also a wide extension of the tumor. Now that oncoplasty can be combined with a reduction or an augmentation mammoplasty on the other side, if the patient wishes so. Again, if the patient is BRCA positive or if the patient has a family history of cancer, she can undergo bilateral subcutaneous nipple sparing mastectomy with implant-based or autologous reconstruction. So many options are available now for a breast cancer patient, which were not available in the past. This is what has changed. So this is how a mastectomy scar would look in the past. We still do have almost 25% of patients of breast cancer who undergo mastectomy. As I said, the treatment is not gone, but other options are available. Then we do a lot of breast conservation surgeries, which is a simple lumpectomy and an axillary sampling or a level 1 axillary clearance. And some of them also choose to undergo autologous reconstruction with the help of tram flap or a latissimus dorsi flap. And then some of them would undergo oncoplasty, wherein principles of plastic surgery are used and breast tissue is mobilized and a better cosmesis is given. Axilla, the treatment of the axilla, like I said, has changed. Previously we used to do total clearance, bare the axillary vein, remove level 1 to 3 lymph nodes, and then the patient used to have a lymphedema and sort of shoulder dysfunction. But now it has gone down to only level 1 sampling. Just we remove the tissue below the intercostobranchial nerve in the axilla, and then if that tissue is negative, we need not remove the entire axilla in select patients. And then it has gone further ahead to remove only the sentinel node or the blue node, which takes up the dye after the dye has been injected in the tumor tissue. So this again reduces the morbidity and improves functional outcomes. So for a patient, typically we use something called as National Comprehensive Cancer Network guidelines. For most cancers, they are available free of cost. And then whenever we see a patient, we try to fit the patient into one of these categories and then decide the treatment based on these guidelines. We even sometimes give a printout of this particular slide to the patient. And this is what has changed in our practice. Previously, whatever the doctor said, the patient had to agree. Now the doctors can justify what they want to say and they also can give an evidence, print out evidence as to why this particular treatment decision was taken. Coming to the common cancers in women, cervical and uterine cancers, both present as perimenopausal or intermenstrual bleeding. Sometimes they present with vague symptoms like white discharge, back pain. Postmenopausal bleeding is a common presentation for carcinoma endometrium. And as we know, they will present to general practitioners also. Ovarian cancer has a slightly vague presentation, lower GI symptoms, maybe a distension, sometimes PV discharge. What has changed is that we use minimal access techniques of surgery for treatment of endometrial cancer. Mind you, it should not be used for treatment of carcinoma cervix because it has been shown to have inferior results in some trials, and never for CA ovary because you will not be able to address the entire, inspect the entire abdomen, which is required for CA ovary. We have techniques like HIPEC, which is intraperitoneal chemotherapy, which is given during surgery, which will help achieve better control because ovarian cancer spreads contiguously in the peritoneum and in the abdomen. So this was not previously available, it has come over in the last 10-20 years or so. And we are now able to do a better job as far as cytoreductive surgery is concerned because of better anesthesia. The complications are managed in a better way, and then because of that, actually the cytoreduction in the form of removal of peritoneum, parts of peritoneum, is actually a very big step in achieving local control. So that is now possible, and we are now aware of that. We also have access to multiple lines of chemotherapy drugs. So although most patients still present in stage 3, we now have options which can treat them in the third stage of cancer and still get some good survival. What has not changed is that the basic tenets of surgery have not changed. We still have to use meticulous technique. We have to remain true to our basic surgical principles despite whatever access method you are using. So if you are doing a minimal access job and you are not able to do a good job, you have to resort to open surgery to give a better outcome. And we do make combined decisions at tumor boards. So a lot of surgical oncology, medical oncology, radiation oncology seats are available. A lot of personnel are available at level 2 and level 3 cities. And there is something called as National Cancer Grid, which allows all of them to collaborate. So treatment should not be a simple decision. It should be taken at a comprehensive cancer care center with the help of multiple specialty involvement like radiology, pathology, nuclear medicine, medical and surgical oncology, radiation oncology, and pain and palliative care services. And we should avoid hasty decisions. We should avoid rushing into surgical therapy, delaying or omitting neoadjuvant therapy, and delay in involving other specialties. Latest technology may be used, but one has to see if it suits your patient. And as we know, we have to keep on changing. We never know what will happen in the next 10-15 years. And we have to accept, learn, relearn, otherwise we'll never be able to grow. Thank you so much.
Thank you, sir, for an amazing talk. I think you've covered the philosophical as well as the academic aspects really well. And given us an overview of how surgical oncology has traversed from the beginning and now in its latest form. It was a very elucidated lecture. Thank you so much, sir. I'm sure everyone enjoyed it. Thank you so much.
Thank you so much, Dr. Amit, for those inputs. May I request the chairpersons to please felicitate the speaker. Requesting Dr. Shriram Joshi, sir, ex-president GPA, to felicitate our chairpersons for the session. moving on.